So friends, hi. You can see here that we are doing the first step, that is mobilization of the sigmoid colon, and this mobilization is happening in a patient who is having 4 accessory cavitatory uterine masses. Okay, not one. Now, of course, the sort of challenging situation which these girls face is incredible amount of pain. Okay, I mean, it is an incredible amount of pain which happens to them. So primarily, because everything is adherent here downstairs, primarily the one thing which I am going to be doing in a situation like this is making sure that I will do the uterines at their origin, surely. Okay, so we have Vismay, and Vismay has done the diagnosis. So can we give a mic to the Vismay, please? He is eating chocolate is what he is saying. You know, these generation Z or what, generation alpha, whatever generation he is falling into, is so weird. Somebody else is also eating a chocolate. Very good. When I offered, that person was not eating. So Vismay,
Yeah.
kindly throw light after you finish eating your rubbish chocolate on the diagnosis of ACUMS, please, for all of us. Arun, record. Open.
For this patient had severe dysmenorrhea,
Correct.
which is very similar to what we have for adenomyosis 2.
That's it, Arun.
And I think the history which was given to me before doing the scan,
Yeah.
it was that it was diagnosed as adenomyosis somewhere else.
Correct.
So I was it was a routine mindset that it might turn out to be the usual adenomyotic
Yeah.
thing, but it started with a retroverted uterus. Then I was able to see this very specific cavitated, you could say, a mass, which was filled with
Saaf karo.
so it's very similar to what looks like on hematosalpinx kind of thing. The blood is collected inside the myometrium with a very
Acha.
specific margin, and it is quite separate from the myometrium.
Okay.
So it is a the whole spectrum of adenomyoma. This part is, I think, called the cystic adenomyoma. In older terms, it used to be called the cystic adenomyoma, and I think the terminology has changed to ACUMS, that is accessory cavitated uterine masses. Still, some people also call it as cystic adenomyosis, because ACUM is generally reserved for, I think, those for congenital cases where the patient has this from birth. So these are actually technically they are called as cystic adenomyoma.
All that is okay.
Yeah.
But tell me one thing, does it change the management?
In terms of who does it, I think it changes the management, sir.
Okay.
For you, I think we have been dealing with such ACUMS. I think we
This is very, very frequent with us. Yeah.
Yeah, and I think we are doing microwave ablation for this ACUMS very
Correct. Beautifully.
But of course, you have to have a intra-op USG.
Yeah. Which we are going to be doing for her actually.
Yeah. So if you are able to do that, and if you have that kind of I don't know. So for us, we can handle it with microwave ablation. Of course, if you are not good at it, you can always do adenomyomectomy or
Correct. And why, like, see, distinctly remember one thing, we will prefer microwave ablation for this.
Yes.
And I mean, I am of that firm belief that microwave ablation will really help these girls.
Yeah.
But what could be a counter sonography machine on, please? What could be a microwave ablation on? What could be a counterpoint for somebody who does not want to do it?
But that is the same counterpoint who does not want to do it for even adenomyosis, sir. I don't think it's different.
That is true.
I think the settings, the fertility part, the damage to the endometrium,
Right.
all that is also applicable to adenomyosis, not
Yeah.
for ACUMS.
Correct.
I think people may say that it's more of a what should I say, a very focalized adenomyoma. So you should remove it rather than doing a microwave ablation. Why to damage the normal myometrium surrounding it?
Right.
But we have seen that if you put a very specific probe, I think we have that
Fabulous outcomes. Yeah.
thin probes with a very small wattage
Yeah.
at a very specific point for a very specific time. It just gets, I think the word is, I think, blasted. I think not even ablated. It that the fluid just gets it gets vaporized.
True.
And the vascularity also goes down beautifully. But yeah, so I think that I think people are more worried about the fertility part, I believe.
Okay. Good. So Visma, I want you to explain the microwave ablation when we do it in this patient,
Yeah.
and for people it should be a good learning point, is what I think.
Yes, sir.
Because when they see the ablation, they will see the radius of sonography. So can we have the scan machine turned on? Simultaneously, can we have the PIP on? So you have the double. Thank you, Santoshi. I really appreciate the speed at which, the one thing which I like about Santoshi is the speed at which she is agreeing to get everything ready. I think very rare. So I'll just separate off all this. See this unhealthy uterosacral. Yeah, this also contributes to pain, for people who think that this does this. This is nothing. This is a significant reason to contribute to pain, isn't it, Vismay? Mike Parbol.
It's very quite evident when we do a sliding test over it.
Yeah, can you explain all that? I want you to actually explain this entire intraoperative sonography. So once the machine is on, ne, Vismay?
Yeah.
Here we go. That is that little uterosacral nodule there. So I really do applaud. There are certain people who do so little, but yet they speak so much. This is one of those situational aspects which one has to understand and study to get to the crux of this, Of course, this is way down into that. We have not done anything to the uterus. We have not done anything to the ovaries at the moment. We are just dissecting off everything from here. And you can notice how strictly it's all got smudged there. You can see that. It's so unfortunate, that it is so badly sort of gone, and just the tissue, the unhealthy aspect of the tissue has just taken over that situation. It's pretty bad for her. No wonder, her pain score is what? Vismay, how much was it when she told you? More than 10/10, I think.
She is suffering from a lot of pain.
On continuous painkillers,
Yeah.
See, remember one thing. I always tell one thing. Patients who are willing to come and get operated in this season. Arun, can we record this, please?
I think she has taken elagolix
with the PIP.
2 months, I believe.
Sorry, Vismay?
She has taken elagolix. I think recently she was on elagolix, then she stopped, and then again she went to a second consultant, and then also she was again kept on elagolix for some
different brand?
I don't know.
Can you explain and justify the role of giving elagolix in this case?
I think you have already you have done so much for them, for the elagolix brands.
Arun, can you record this better?
But I don't. sonographically I don't feel I have all the patients. But just I want to tell you one thing. I think recently, since like 3-4 months, a lot of patients have been on elagolix.
Yeah.
It's like the new, I don't know.
New diagnosis.
New diagnosis, yes.
True.
Before 6 months I used to hear on diagnosis. Now it is quietly shifting to elagolix. I don't know, but the shift is happening.
Yeah. Yeah, gown. So see, here we are. You can see the dissection now, near complete dissection. Everything cleaned off basically from one end. The reason why you got to clean this off like this is in order for you to make sure that when you clean it off like this, you know, whatever ablation you do, it's going to be in a particular cavity only. Okay. So Arun, is the PIP pointing towards the suction, please? Now this is going to be very interesting for guys to see. The uterosacral nodule and everything has been taken off. No need to worry. See this? This ovary is free. So I'm not going to do anything. Uterosacral is okay. Not going to do anything. Preserve the fallopian tubes for the girl. Microwave ablation probe cooling 14 degrees please. So it's okay. I just want Vismay to come on the scan. Santoshi, ablation probe please. So friends, I wish each and every one of you a wonderful happy Diwali, because I'm sure you know people are in the Diwali mood by now, and obviously the Diwali window is such, you know. Screen off, PIP on please. Thank you. I'm not going to be doing anything apart from that uterine artery which I did, because that was a large uterine artery, and Arun, record that also. Upar. Double. Ask Santoshi to do that. Vismay, I want you to explain this in details. White phone se Santoshi. On the screen. This screen. हाँ ठीक है ना, लाइट बंद करो. Guys, Vismay, can you please explain everybody what exactly you are doing?
So here you can see a retroverted uterus.
Yeah.
The endometrium is seen in the middle.
Nahi, I don't think people can hear Vismay because he is not having a mic. So the best way to make Vismay speak is speak on this. It's okay, Vismay. Speak on this.
You can see now it's a retroverted uterus. So pointer. Okay. It's okay.
See this.
This is the endometrium in the middle.
The endometrium. See, this
Yeah,
is
the endometrium, retroverted uterus. Now, if you see that the fundus area, now that my probe is on the right lateral wall, you can see this one ACUM.
This is ACUM number 1.
Yeah. Then I'm going to the left.
Beautiful.
Two ACUMs over.
And ACUM number 3.
Yeah.
Correct, Vismay?
Yeah, and one
that
more.
small one. ACUM number 4 there.
Yes.
Cystic adenomyoma number 4.
This one.
Correct, na?
Yeah. And if I go and coming back to the center and just rotate my probe, now you can see everything in. So this is the left lateral wall, and this is the right lateral wall. You can see the endometrium behind. So these are more anterolateral. Here.
Correct.
See.
So now we will start with our probe, and we will put the microwave ablation probe inside, and under Vismay's guidance we will start puncturing the cystic adenomas one by one. Okay. So there comes the thin probe which Vismay is speaking about. Jo Vismay, correct hai? I am primarily going in this one. I am primarily going in the left one. Okay, 3, 2 અને 1. Arun, can you record this on the main screen also? Yeah, main screen para Arun. Yeah, can you on? Now, just to show you guys, see how beautifully my probe has come inside on the PIP. You can see that. Now, can you do a double one, Santoshi? Thank you. Double dikh raha hai? See this. My probe is right inside. Okay? See? Arun, usko record karo upar. Main screen pe. Santoshi, if you can help my beautiful Arun. See this. You can see the beautiful probe inside. Correct? दिख रहा है संतोषी वहां पे? Okay. On the ablation. 4-5 सेकंड इनफ था वो. On the ablation. Vismay, can you show them? Can you see the? Can you make the PIP larger, Santoshi वहां पे? Now remember one thing. Once this is ablated, okay, it will blast. Huh? That is the word which Vismay has used. Fantastic. Okay, bhav band karo. Now see, why did I ask him to stop? Just look at this. Track formation will occur, and through that track formation, whatever is to come out, na, first it will come out. Again, karo ablate. See that again I have come in the right in the center. Let it ablate. Okay. Let it keep on ablating that region. It will just crumple this tissue without damaging fertility. That is very, very important for me. Okay, stop. Over. See, on the main screen, see how beautifully it got let out. The entire unhealthy material, see this, just completely gone from there. Same hole I will use, and I will go little more lateral in that window. Karo ablate. Let everything get burnt. My target is to kill it. कितने पे रखा है? ठीक है, थैंक यू. After this, of course, we will give the lady an injection of Zoladex. But we are preserving her entire fallopian tube architecture, everything, by doing this. Let it get burnt first. This will require more rounds because that part has to get killed. I am telling you guys, it should not be burnt, it should get killed here. So let it happen slowly, slowly. No problem. Slow and steady wins the race here. Okay, band karo. See, I am slowly, slowly stopping so that whatever tissue which is present there, and I am trying to compress that tissue, if you see, without damaging the serosa. The target which I have is to basically go through that singular hole. इसमें जो तो कर अब्लेट 6 એમાં દેખાય છે બળેલું આખું કેવિટી ગઈ એની અંદરની કેવિટી ગઈ ઉડી ગયું ને જસ્ટ પીઆઈપી સંતોષી જવા દે ને હા ગયું ને so now see one side is gone finished okay see that tract you can see the whole thing getting absorbed only can you see The whole adenomyomas region is only getting absorbed. बंद कर. Now, after it has got absorbed like this at one end, see there is one more chota sa end here. Yeah, here. So, first I will rupture it. See, when I rupture, you can see that chocolate color being let out. See, see, beautiful. करो जलाओ. And then I will burn it. नहीं चलेगा संतोषी. बंद. See that? जलाओ. Save the tubes. This is good. I am happy. Band. Okay. Now, let's go to the other side. Vismay has mentioned two more here. Cooling karo. Vismay, can you show that on ultrasound to people now? Santoshi, PIP on the PIP for the scans. Now it is going to be on the right side of the patient, so Vismay is going to be able to show it to you nicely. देखा जाए? Can everybody see the screen? Two adenomyomas there, beautiful ones. First one I am going to rupture now. Shall I? Vismay करूँ? Double दिख रहा है संतोषी? आयो? આવી ગયો? કે હજુ અંદર આવું? करूँ? ओके जलाओ. Let the ablation happen. Record that, Santoshi. Main screen. And of course we have one more adenoma in the center. Gayu Vismay? See, this is double, two people taking the efforts to give happiness to one patient. Stop. Cooling. Cooling. છે હજુ ને? ઓકે. હા, કઈ સાઈડ? આવી રહ્યું ને? જો આવી રહ્યું. હું અહીંયાથી અંદર આવ્યો. જો હું આવ્યો. Exact? See that beautiful full fluid let out. Rajo, akku fluid bare. See, once the full fluid is let out, na, then what we will do? See this whole fluid you can see getting let out. I can see it. Oi, hoi, hoi. Jala. See, once the fluid is out, please remember, ureter is going here. This is that little uterosacral attachment. Bas, this much is enough. You can see we are trying to burn that thing. बंद. Okay. See, this is the thing, we always have a uh, singular probe. So you must make sure that for all these types of singular probes, your probes are beautifully oriented all the time. When the probes are oriented beautifully all the time, let them just clean the probe. It takes some time for the probe to get cleaned. Let it just get cleaned up. Some little bleeding there. Actually, the entire procedure is going to finish without any bleeding. Let the probe get cooled off. So we are going to the lateral aspect the first, of course. This is where I should go in, exactly here. Okay, start. You can have such a huge amount of yeah, बंद. एक बार और सेंटर में कर लेता हूँ. लेट द फ्लूइड बी आउट. स्टार्ट. ओके, स्टॉप. आई वांट लार्ज प्रोब नाउ, क्योंकि मैंने ये बर्न कर दिया अभी. लार्ज प्रोब्स प्लीज. Let the large probe come in. I think till the large probe comes in, we just have 2 more spots to go, isn't it, Vismay? Fine. Come, ऐसे पकड़ लो इसको. Let उनको नया probe लाने दो. I have requested my staff to actually give me a new probe because I'm wanting some more ablation radius there. The entire journey of doing this is going to be dependent on the type of probes which you will end up using, and majority of the times in our country, in India, people will end up using reused probes. That is the big problem, which you should never do it, because now see, as you sort of grow in the science, you realize that these probes are not meant for multifunctional usages. These are probes which are meant for singular usages only. Of course, considering the situation of India and considering the manner in which ablations would happen here in India, it's so distressing to watch, as Vismay said, Ella Golics, this, that, 100 things have been provided to this girl. Let's come in with a thick, this probe which I am now coming in with is a thicker probe, and let it just get cooled off. See, the thing with the cooling is, once the cooling occurs, cooling hai? Yeah, cooling is happening. વિષમાં હું સેન્ટરમાં આવવાની ટ્રાય કરું છું. ઓકે, સ્ટાર્ટ પ્લીઝ. ઓકે, સ્ટોપ. So the probe is beautiful, fresh probes. See this. Start. Bhaiya start karo. Now you will see, Vismay, the old one. Huh? You will see that I have gone and I will just sap out the old one, and then finally I will come to the central adenoma. Evidently you will see the necrosis here, and evidently you can see the amount of chocolate fluid leaking out. See? Okay. Stop. See, that entire chocolate thing has got cooked there. Last bite. Entry. Okay. Udao. Visma, you can probably confirm the amount of ablation radius which has been achieved, and as long as once he is satisfied, I am done. Satisfied? Okay, done. Stop. Fine. Some discharge will occur now. Vismay, क्या છે next? અહીંયા છે? હા, આવી રહ્યું. મને દેખાઈ ગયું. So I just want to point out to Vismay, સેન્ટરમાં છે કે નહીં એટલું બોલ ખાલી. Okay. How? Okay, so here it is. See this. જોઈ લે. Switch internal. છે? જોરથી બોલ. Endometrium is beautifully protected. લે હવે happy? Very nice. So whatever is there, it's all got cooked up, I think now. હે ને વિસ્મય? કઈ બચ્યું નથી ને? ઓલું પાણીનો મોટો માસ હતો એ? Gone? So let Vismay show you the ultrasound as soon as I finish this, and then I will use one more ablation radius. No damage to the fallopian tubes. That is the beauty of this. Huh? Okay, बंद करो बेटा. See this, such a huge amount of chocolate colored discharge is occurring from there now. જોઈ લે વિસ્મય એકવાર. Let the Vismay see. Once he is satisfied. Oh wow, look at the endometrium. Beautiful. Just want to show you the endometrium here. See this. This is the entire endometrium protected. Nice. છે વિસ્મય ક્યાંય? માઇક પર બોલતો જાજે.
This is the endometrium.
હા, this is in the center, right? This is the endometrium.
This is all the ablated part.
Fantastic. See, this is the reason why people should not choose to do ablations at places where people have no specializations. You kindly must try to make an effort that for your body you should go to a specialist. We often see from myself and Vismay, start kar, that people will offer ablations at 1/3 our cost. Okay, 1/3. नहीं Vismay? કેટલા આપણાથી તો 1/3 કે 1/4 है ना?
मतलब people have I think many people have also asked for the machine, the wattage, the cost, to even to me.
Yeah.
And how मतलब so people are trying to do or wanting to do or are already doing it.
Correct.
And yeah, we are also getting
lot of redos.
Yeah, we are also getting a lot of redos.
One has to be very careful, because see, ultimately when we get so many redos na, that is not a very good thing. बंद करो बेटा. Somewhere something is going wrong. The technique maybe, or
I don't know. People are also trying a lot of percutaneous.
that is also highly wrong, many times I think. Chalo, start. See, the good thing is now when people try all these percutaneous things and come, see, kindly remember, as we have already, published, ours is the largest series in the country for doing these percutaneous ablations. But you have to be super careful in choosing your patients. This patient, no way in which you could have done percutaneous. The reason why she has got a recurrence like this in just 1 year, okay, is because of all this only. Chodo. And see, now what is happening is, with the awareness about ablation spreading across the world, no, okay, these are all these patients in whom somebody has come and done percutaneous, band karo beta, percutaneous procedures in some workshop. Whatever was the effort which was taken, 5 people, 10 people learnt, whatever, okay, but at the cost of the patient, I don't think it is good. I sort of don't agree to that. Probably even Vismay would not agree, hai na Vismay?
Yeah.
It should not be at the cost of the patient, I think. Band karo. Band. Fine. Ureteric dissection, guys, is a key thing. Vismay, can you highlight why we are so insistent on ureteric dissection being done nicely?
You can see for
But
this particular ablation, which we are very lateral.
Yeah.
So there is, look, we already know there is a lateral spread for the microwave ablation.
Oh, it's heavily, the entire technology is dependent on spreading laterally.
So it is the thing, na?
See, you can see that discharge coming from center, guys. That is very important in this case. See this. This has to come out. This is the necrotic discharge.
Yeah. It sometimes also comes out through the endometrium.
Yeah, sometimes can come out through endometrium also. Very, very important. Band karo beta. Band. Camera saaf karo. Maybe my last percutaneous ablation probe here. Very, very quickly, I would not, as I told you, I strongly don't recommend doing it just percutaneously.
Doing it without laparoscopy.
Without laparoscopy and ultrasound guidance. What is the harm? Just, these are our redo cases which we are posting. So that means somebody has attempted all this before, guys. And that somebody is not we. Otherwise the patient would not come to us. Okay? Come. Jalao beta. बस जस्ट लास्ट है ये. रुको मैं बोलूँगा आपको. ओके जलाओ प्लीज. See, try to burn that entire radius from 3-4 different walls. I always try to make a mental map of the disease in my head first as soon as Visma is doing a scan. And once the mental map in my head is ready, only then I go ahead and start the ablating aspect in multiple radiuses. Please keep that in mind. है ना Visma? That is very, very critically important. Lateral window.
Mapping is very important.
बंद कर दो बेटा. So you may feel that array this has come to the serosa, not correct. Now give me suction. Suction do और पानी दो. So people may feel that array nahi this is not how you should do. Serosa should be protected. This that. But remember one thing. So now guys, I think we also have the highest case load for looking at all microwave ablation complications, isn't it, Vismay?
Yeah, yes.
The amount of microwave ablation complications which we have handled as a team here, it's incredibly high. Correct? Fistulas, this, that. Pani chalu karo beta. I want to show you what exactly happens to the serosa for people who are scared, no? Just see now. Band karo beta. Pani band kar lo. Thank you. Look. This is what you are trying to achieve. See this. Endometrium is still completely fine, just to tell you. See this. These small holes, small holes which have been drilled here. These small holes which have been drilled here. See, this is so hard. Can you see this structure? How would you have done an adenomyomectomy here? I would want to understand from anybody. Without damaging the tube, how would you have done an adenomyomectomy here without damaging this? This hardness will get liquefied over a period of time. Okay, now that I have put water, I have understood that that part has become blanched. So that means the heat has reached till that level from inside. That much is more than enough as far as this patient is concerned. Thank you so much for watching us live. Obviously, you may have questions and we shall be very happy to answer your questions. Bye bye. Take care and God bless you guys. इसमें है ना